Thank you so much for taking the time to discuss the state of obesity. I feel this is a very important topic in our world and medicine, but also socially. And today I'll talk more about the disease state. I will talk a little bit about the treatment options, but it's important for us as all medical practitioners to understand that we're all treating patients with obesity. And it's very important that we know how impactful this condition is on our patients. So I'll talk about the medical, pathologic, epidemiologic, provider-centric state, as well as the patient experience, because it's important for us to know how the patient feels. This is a unique form of medicine in which the patients are often stigmatized. Sorry, I realized my video is not on. Patients are often stigmatized in a way where they can avoid medical environment. So it's our responsibility to help the patients feel comfortable discussing their weight. So there are many medical definitions of obesity. So we have BMI, which is very commonly used, and that's a height-weight ratio. You see different classes of BMI here, varying from normal weight, overweight, and 3 classes of obesity. Now, this is not a perfect way to measure someone's health, however. You can see we have 2 individuals here, both with the same BMI, but different body types. So we need to look beyond using the height-weight ratio as a way to determine if a patient has obesity, because obesity is a condition that's classified by increased accumulation of adipose tissue. And you can see our gentleman in the blue has more adipose tissue than the gentleman who's not wearing much at all. So we look at other measures such as percent body fat. In my office, I actually do measure body fat percentage. We have a body composition analyzer where patients really step on this fancy scale and they can determine if their body fat is too high or low, or if it's a normal range. So this is also something that we can use to classify obesity when we're trying to, one, justify treatments for obesity, and also determine if the patient should continue to lose more weight, more than based on just their BMI. We can also use waist circumference. This is very easy to measure. Tape measure costs less than $1. We can always get these from our local drugstore. So I do measure the abdominal waist circumference in our patients when we come in. And we look for the goal to be less than 40 inches in males and less than 35 inches in females, because this is more correlated to subcutaneous fat tissue. Another tool that is used more in the obesity medicine realm is the Edmonton Obesity Staging System. And this is a unique system because not only does it encompass the body mass index, height-weight ratio, but also has to look at other factors, symptoms such as reflux symptoms, shortness of breath, which I know you see commonly with patients who are victims of World Trade Center. This can be also continued to look at by mobility, if the patient has other weight-related conditions. And also it looks at psychological factors. So this is a more global, comprehensive way to stage obesity. And we do use this in the medical field to determine not only the patient's severity of obesity, but also what their treatment options are. So you see here, it looks at the medical height-weight ratio, whether they have weight-related conditions, the mental aspect of it. Is the patient being stigmatized in their social or work environment, as well as functional? Are they having debilitations due to either shortness of breath, lack of mobility, etc.? So this is another way that we can classify obesity. I will state this has not been widely adopted by, say, insurance companies or even medical societies, but we do use this in the obesity medicine realm to help understand how severe a patient's obesity is, and thus how much we should treat. You know, if a patient is in a stage 3 of the Edmonton Obesity Staging System, we might consider them for surgery faster than someone in stage 2. We might consider pharmacotherapy options. So this is another way to classify essentially how sick someone is from their obesity. just as we have with type 2 diabetes. We have normal glucose, pre-diabetes, different stages of diabetes. So this is not a foreign concept to medicine. We use this in many different conditions. We have pre-hypertension, hypertension. We use the same thought process with obesity. The other reason that we are looking to move away from BMI is because what you can see here on the right side of your screen is NHANES data looking at the correlation of BMI, body mass index, with morbidity and mortality, really. And it really does not correlate unless it's at extremes of obesity, extremes of BMI. So low BMI, under 18, people might have cancer, they may have malnutrition, and those people are likely to have mortality. Extremely high BMIs, BMI 50 and up. These patients are debilitated, may have multiple medical conditions, but also don't have a lot of mobility, so they have very high risk of mortality. But in the middle, you see there's not much difference in the mortality risk looking at BMI. However, on the left side of your screen, you can see that looking at the Edmonton obesity staging system, there is much more correlation. This blue line is the EOSS level 3. This is the patient that has both the physical, the psychosocial, the mental, and the medical aspects of having severe obesity. And there's a very clear delineation of mortality risk with Edmonton obesity staging system. And I'll just note, I borrowed these slides from Dr. Sharma, who developed the Edmonton obesity staging system. And it's named that way because he practices in Edmonton, Canada. And you see at every different level of BMI, the EOSS really is correlated with mortality. So again, this is another factor that we're using to consider not only treatment options, but severity of obesity and how aggressive we should be with different treatments for patients with obesity. So just to summarize about the Edmonton obesity staging system, it's easy to determine. You look at the BMI, that's easy to calculate. Patients look at their weight, their height. The electronic medical record often calculates that for us. Now, we can take into account how's the patient's mental status. Are they having depression? Are they stigmatized because of their weight? Have they been in such a poor state of mental health that they're maybe staying in their homes? That they're avoiding social settings. These are things that are hard to really assess without really asking the patient. And then we look at the medical conditions they may or may not have, as well as their functional status. So these are things we do have to tease out from the patient. It's more than just calculating height and weight. We need to understand the patient's day-to-day aspects of living to determine how severe their obesity is and how it's affecting them. And that is a better correlate of their risk of death and weight-related comorbidities. This is a better measure than BMI or waist circumference. But of course, it takes a little more teasing out again of the patient to determine these. And we're looking in the medical society to move more toward this type of staging system and away from BMI, because we know BMI has some faults. Just as we saw the two cartoons there, we know that especially in Asian patients, we can have lower BMIs that are considered normal, BMI 24, but patients can have significant disease, type 2 diabetes, fatty liver disease, and that's why we really aim to treat for conditions that are related, not so much for BMI. So I urge you in your practice, as you see patients with respiratory illness due to World Trade Center, due to other things, to consider the effect of their obesity, not only as height and weight, but how that's affecting the patient from a mental status, a functional status as well. Again, there are many definitions for obesity. This is the Obesity Medicine Association's definition. And it is quite wordy, but I think it's very comprehensive. And it's defined as a chronic, relapsing, multifactorial neurobehavioral disease. And that's a lot of words, but basically this is a condition that the patients will have if they have a high height weight ratio, they'll have this condition forever, even when their weight normalizes. It's a chronic condition and it's relapsing. It can come back and it can go away. There are many reasons someone might have obesity, and we're not always able to elucidate why the patient has obesity, but we know that this is a condition that we'll have to treat them for life. And it's not a condition that's really looking at from a social aspect. It is a neurobehavioral disease. And I'll talk a little about the neurohormonal aspects of obesity as a condition. And what is the effect of it? It's basically this dysfunction of adipose tissue, where the adipose tissue is a hormonal uh, organ, just like a thyroid, for example, or an adrenal gland. And if the adipose tissue becomes dysregulated, meaning it's getting bigger and bigger and bigger, this can cause dysfunction that not only promotes fat mass disease. For example, a patient who has a lot of adipose tissue will have a buckling of the knees because there's a lot of mass, but also inflammatory states. The adipose tissue releases cytokines that causes the patient to have other metabolic diseases, such as type 2 diabetes, heart disease, etc. So these are the reasons that we consider obesity as a chronic condition that should be treated very aggressively, because the patient can have debilitating effects, both from a fat mass disease and from the inflammatory effect of the increased adipose tissue. Now I can get into this slide, which details all the different reasons why we have obesity, but that would take probably the rest of the day. So I just want to state that obesity is a multifactorial condition. So we'll talk about some of the pathology related to obesity. So I mentioned earlier, this is a neurobehavioral condition. And I'll start here with the brain and relate that to the stomach. So the gut-brain axis is really what's affected when we have obesity as a disease state. So the stomach is sending messages to the brain, the intestines are sending messages to the brain, the pancreas is sending messages to the brain, adipose tissue, liver, all sending messages to the brain about whether we're full, whether we're hungry, whether we should eat, whether we should stop eating. And in respect as well, the brain is sending messages to the gut about what to do with digestion and how fast or slow the stomach should empty. So I'll talk about some of these neuronal hormonal effects that we start us having a condition of obesity. So I'll start with the stomach here. So the stomach releases ghrelin, and ghrelin is a hunger hormone. You can remember that by thinking of ghrelin, grr, the stomach growling. When someone is getting a hunger signal, that's coming from the hormone ghrelin. This then goes to the brain. There's the arcuate nucleus of the hypothalamus, which is our appetite regulation center. And if ghrelin is highly activated, then the brain gets a message to tell a person, you should eat. The stomach is empty. We need to digest something to get energy. And this is the main hunger hormone that we know of. I really think there are others that we have not found yet, but right now we know that ghrelin is a hunger hormone, and that's sending messages to the brain to increase the neuropeptide Y, a GUDI-related protein area that tells someone to increase food intake. Now we have several other hormones in different parts of the gut that tell the patient to do the opposite. So we have GLP-1 from the L cells of the intestine, and this tells patients, you are getting full. Stop eating. This sends a message that's called an anorexigenic hormone to the brain, and that activates the POMC-CART area of the arcuate nucleus of hypothalamus, and that decreases appetite. Tell the patient, you're full, you should stop eating. Similar hormones come from the pancreas. Insulin also has a similar effect. We have neuropeptide Y, and we have leptin. Leptin actually comes from the fat cell. So up here, what you see, this yellow fluffy tissue is, again, the endocrine organ that is adipose tissue. And the more fat cells the patient have, the more leptin's released. And that sends a signal to the brain that, again, you should stop eating. It's anorexigenic. Now, One would think that someone with a lot of adipose tissue would get a message to stop eating, but we know that this is not true in the state of obesity. Just as we have insulin resistance and diabetes, patients are making a lot of insulin, but the muscle cells aren't responding to it. In obesity as a disease, we have leptin resistance, where the adipose tissue is releasing leptin, but the hunger is still present. So there's a leptin resistance, and this is another part of the dysfunction of obesity as a condition. Now, we know obesity itself is a disease. However, it's associated with many other medical conditions. And that's why, again, I state we're all treating obesity. Whether we're treating pulmonary disease, gastroesophageal reflux, cancer, all of us are treating patients with obesity. So it's important to understand how complex this condition is and how it needs aggressive treatment. Again, here's a more simplified version of the slide. I had two slides ago. And basically, you can see the gut-brain axis. The adipocytes release leptin, which go to the brain to decrease appetite. Ghrelin comes from the stomach to increase appetite. The L cells of the intestine secrete GLP-1, GIP, cholecystokinin, and peptide PYY. And the pancreas releases amylin and insulin. So you can see again here a simplified effect of the simplified version of the gut-brain axis. And I show you this slide in this way to help you understand that these are targets for our treatments for obesity. Of course, we know GLP-1s are very commonly used now for treating obesity. There have been some studies done with leptin analogs. There's nothing that's really on the market yet that is proven to be effective. And we also are using GLP-1 GIP agonist as medications, and they're looking into agonists of PYY. I'll also state that the stomach releasing ghrelin is an important factor to remember. The ghrelin from the stomach gives patients a strong hunger hormone. And when we think about bariatric surgery as a treatment, let's say a sleeve gastrectomy, about 70% of the stomach is removed. So the patient has fewer ghrelin receptors, and that's why there is a target for sleeve gastrectomy to decrease hunger. However, the body is very dynamic. When a patient has a sleeve gastrectomy, the ghrelin levels do decrease, but we do see that increase after about 2 years because the body is trying to fight back against weight loss. And I'll talk about that concept a little bit later on. I can't give this presentation without mentioning the effect of obesity and COVID. We know that in patients with obesity, COVID outcomes are worse, especially with the initial pandemic. There was a 3 times greater risk of hospitalization. As BMI increases, the risk of death increases. And actually, when looking at comorbid conditions, obesity was the highest rated condition in patients under age 65 that correlated with ventilator use, hospitalization, and mortality due to COVID-19. So you can see here, patients under age 65, looking at different conditions that were present, obesity ranked very high in the younger population as far as those who are hospitalized with COVID. And this data comes from a multi-center study called COVID-Net. So I'll talk a bit about epidemiology. Undoubtedly, I'm sure you've seen these CDC maps looking at the prevalence of obesity by state in the United States. And here I just want to point out, I'm from Georgia. So the South and now a lot of the Midwest as well have very high rates of obesity. And if we were looking at this graph a few years ago, say 2016, there were actually some states that had this green pattern, this green dotted pattern, where there was less than 20% or less than 25%. But now we have no states that have less than 20% obesity. This epidemic is increasing, and it's affecting not only our medical aspect of health, but also the economic effects of obesity as a disease. The other thing I want to point out here is that there's differences in ethnic disparities with regards to obesity as a condition. And you can see here in the box, it's a very high, almost 50% in non-Hispanic Black population, about 45% in Hispanic population, 42.2%, this is an American white population, and 17% in Asian populations. And this is just based on height weight ratios that is self-reported. I just want to point that out because we know that self-reporting of weight can tend to underestimate weight. So these values may be even higher. Now, if we're looking at the Hispanic population, 44.8%, we see differences in ethnicity. And if we're looking at self-reported, this is non-Hispanic white Americans, we do start to see a little bit of a lower trend based on BMI, but we know that there can still be high health-related conditions even when someone has overweight in a non-Hispanic white population. And this graph looks at the Asian population. Again, I want to point out here, we do start to see that green pattern, the green dotted pattern, when there's less than 20%. However, this is based on BMI. And we know that in Asian populations, there can be weight-related conditions such as fatty liver, type 2 diabetes, heart disease in a lower BMI. So there is a push to move the BMI ranges for Asian populations to start overweight at BMI 23. So you really don't have to wait until a patient who is Asian descent has a BMI of 25 to start treating obesity. And we can actually advocate for patients to have medications at a lower BMI of Asian population and also for surgery as well. This is very much still a work in progress. The medical societies, as far as bariatric surgery, have started to adopt this. Insurances, as far as getting coverage for medications, it's a little bit harder. I have been able to advocate for Asian patients to get medication at a lower BMI, but it does take some extra work with writing letters and doing authorizations and peer-to-peer review. So again, we understand that BMI is not a perfect measure of obesity, and there's still more work to be done to find a way to easily calculate risk of mortality that's related to weight. And so that's why we use things such as the Edmonton Obesity Staging System. I measure the fat percentage in my office, which is easily done. It's a little bit of an expensive machine, but it is really worth it. And then also we can look at patients' weight-related comorbidities as a measure for how we should treat them. Now, there are many population-based initiatives, which I'll point out here. Our policymakers, our senators, our legislators, our governors have really started to understand that obesity is a condition. It affects our medical state. It affects our economy. So you see here, there are different population-based initiatives that were started in various neighborhoods, cities, to help our patients with obesity and also to prevent obesity, not only in adults, but in children. There have been interventions such as having talks like this in communities, promoting healthier food and beverage choices. I'm sure you remember the soda tax that was implemented in New York not too long ago. For example, SNAP, the healthcare system that was really designed to help patients with food insecurity have access to food, really is starting to trend more toward foods that are not high in high fructose corn syrup or high in sugar. So promoting healthier food and beverage choices, not only in homes, but childcare societies, childcare settings, schools, etc. I'm sure, no doubt, you've seen these fruit stands pop up everywhere in New York. So that is actually an initiative to help promote access to healthy foods and also inexpensive foods. These are ways we can get patients to have more fruits and vegetables in communities where they may have food insecurity or they live in food deserts. prior to these fruit carts being available. Promoting nutrition standards in early care, health settings, education settings, food pantries, churches, designing communities with bicycle lanes. We see a lot of that in New York. More sidewalks to promote people walking, parks, etc. Access to community-based education centers, and also screening for obesity. They're moving away from this right now, but previously, about 10 years ago, everyone in the school system the children would get their height and weight measured, and the parents would get a little note home to say, your child's BMI is this, and either it's normal or it's high, and you should do something. And I really think if we're going to do that, we should take it to the next step and offer safe, effective treatment options, but that then necessitates us to have more providers available to help those parents. Because we know that obesity is more than eating less and moving more because of the neurobehavioral component of that. Despite all these population-based initiatives, obesity rates are still increasing. So it does take more than knowledge, eating less, moving more, access to healthy foods, sidewalks, and bicycle lanes to really get us results. The cost of obesity is astounding. It costs almost $2,000 more per year to treat a patient with obesity than a patient with normal weight. And we know that 44% of America has obesity. If we take into account obesity and overweight, that's 70% of Americans. So you see that the cost not only on physician visits, inpatient care, prescription drug use is quite astounding. And this, of course, impacts our economy as well as our medical settings. And this is a shocking statistic. After smoking and armed violence, obesity is the third largest direct economic impact in the world's economy. So I'll touch on treatment options just a bit. Lifestyle modification. This is diet, exercise, and behavior. It is an option for everyone. Everyone in the audience, all of our patients, we can all have lifestyle recommendations. And that can vary over time. That can mean counting your calories. That can be going to a community-based or web-based, app-based program to help get a dietary plan. It could be doing some practices that help decrease stress. That's activity, whether that's your activities of daily living, going to a gym, working with a trainer, and it also is behaviors, timing of eating, drinking water, chewing, the order in which you eat your food. So everyone has access to lifestyle modification. And this is an important basis for treating obesity. Whether we're preventing or treating, lifestyle modification is very important. However, we know that with the studies that are done with pharmacotherapy and surgery as a comparator to placebo, the placebo is not zero interaction, it's lifestyle modification. And we tend to see about 2 to 3% weight loss with lifestyle modification. So this does not work for everyone. And I want to point out, if the patient has obesity, it doesn't mean that they're not practicing lifestyle modification. It means that lifestyle modification is not working for them. So we should give them that recommendation, but also consider stacking therapy. Prescriptive nutritional interventions. This is something that I offer in my practice, where patients have specialized diets, sometimes involving meal replacements, timing of food, getting more and counting calories and things like this. So this may require referral to a weight management specialist or dietitian. And if that's not effective for the patients, we do have more efficacy with pharmacotherapy, where we can get 10, 20, even higher than 20% weight loss in our patients now. There are endoscopic tools. We're seeing more of endoscopic sleeve gastrectomies. What you see in the picture here is a balloon that is used to help generate weight loss. I will say the balloon is a temporary measure. It only stays in the stomach for about 6 months. And then also we have bariatric surgery. And though on the slide here you see these therapies stacked on top of each other, they do not have to be linear. There are patients who have bariatric surgery who then need medicines. There are patients who are always doing lifestyle recommendations, and this can go back and forth. The point I want to make here is that patients will always need care for their obesity, even if they're normal weight and they're not having medications, they're not having surgery, they're still using lifestyle modification. So it's important to, one, diagnose obesity based on either BMI, waist circumference, fat percentage, or using the Edmonton Obesity Scale. The reason it's important to diagnose this and actually put it in the chart is it helps our healthcare system be aware of the impact of obesity and how prevalent it is. And also it helps us as professionals advocate for obesity treatments. So it's important to diagnose obesity. And you see here on the left side of your screen, as the severity of obesity increases, patients do have more treatment options. So pharmacotherapy is indicated when patients have a BMI of 27 with a comorbidity or BMI 30 and up with or without a comorbidity. And the treatment options for surgery are actually starting to, again, be a little bit more liberal, where some insurances are considering BMI 30 and up with a comorbidity for bariatric surgery. But if patients have a BMI 40 and up with or without a comorbidity, they are currently candidates for bariatric surgery. And this is a very simple schema of the different types of medications that are available and different types of treatment options and their efficacy. So we're looking at patients in different programs. So let's say patients on intensive behavioral therapy. This is seeing a dietitian, counting your calories, doing lots of exercise. The likelihood of losing weight increases with the aspect of how aggressive we're being with the management. So patients are considered to have results, considered to have some type of response if they've lost at least 5% of weight. To put that in perspective, that's a 200-pound patient losing 10 pounds. And while that can have some impact on their health, we know that patients want to lose more than that. The patient who weighs 200 pounds usually wants to lose about 40 pounds. So that's about 20% weight loss. So as you look at these different categorical weight loss, 5, 10, and 20 or more percent, keep in mind the patients, they tend to like to use 20%. I ask the patients, where would you like to be with your weight? And when I calculate it, I really get around 20%. And another interesting phenomenon is patients say, when I ask them what weight would they like to be, they always go to their high school weight. That's where they want to be, their weight in high school. And so we say that may be a dream weight, but let's look in percentages, because not only do we want to make the patient happy, we want to improve their health. We want to increase their longevity. So looking at the likelihood of achieving meaningful weight loss in different treatment options, we have, for example, here, patients on a behavioral program. Let's say there's an online app they're following, they're counting their calories on that app. So using that type of model, about 50% of patients will lose 5%. Again, a 200-pound patient losing 10%. But as we get more, losing 10 pounds, sorry. As we get into the higher categories, using lifestyle modification, patient has about 10% chance, and even that's high when you look at some of the studies, of losing more than 20%. Looking at bariatric surgery, patients who will lose this amount of weight at 10 years, they have a high chance of losing more than 20% at 10 years. It's about 70% chance. When looking at liraglutide 3 milligrams, and again, all these drugs are used in conjunction with lifestyle modification, many patients will lose 5%. 74% of patients will lose 5%, and about 36% of patients will lose 15%. Looking at semaglutide, 2.4, which is indicated for weight management, a lot of patients, about 90% of patients will respond with 5%. However, I want to point out that means that 10% of patients are non-responders to GLP-1 agonists. And I know there's a lot of press and interest in GLP-1 agonists. I prescribe them widely. There are patients who do not respond. So we need to use other modalities to help those patients. Looking at 20% weight loss with semaglutide, we see about 36% of patients achieve the 20% weight loss that they desire. When looking at phentermine topiramate, another oral medication for weight management, about 67% of patients are getting 5% weight loss. When we're looking at 20%, it's about 15%. And the other medication that's indicated for weight management is bupropion naltrexone. 5% weight loss is about 66%, and about 29% of patients will achieve 15% weight loss. So while these numbers vary and there's clearly a winner here, it's important to know not everyone will respond the same. And we must use different treatment modalities, the lifestyle, medications, and potentially surgery with patients to be treated for weight management. And that treatment will continue for life, and it will change over the aspect of someone's life as well. I do want to touch on coverage because a lot of times I get questions about, well, these medications work, they've been proven to be effective, but I can't get them covered for our patients. So I will just discuss, for the sake of brevity, the current state of CMS treatment coverage. Part B, Medicare and Medicaid, does cover obesity behavioral therapy, and that's basically nutritional care, seeing a dietitian, getting some recommendations. That is covered with some specific guidelines. The patient has to be seen a certain amount of time. If they lose more weight, they can continue treatment, etc. Bariatric surgery is covered by CMS with BMIs over 35 with comorbidities, or BMI 40 and up with or without comorbidities. But currently, as I speak to you today, and in New York State, medical therapies, pharmacotherapy for weight management are excluded by Medicare and Medicaid. So many of our patients are using these treatment options, this in coverage for their care. They have access to dietitians, they have access to surgery, but they don't have access to pharmacotherapy. And this is abysmal, I believe. It really precludes patients who are BMI 25.1 to BMI 29.9 to having access to therapies. And we try to prescribe these medications, but statistics have determined that 80% of prescriptions that are written for anti-obesity medicines, that's AOM, are not filled due to lack of coverage and high drug costs. And this is a shame for our patients who don't have access to therapies that have been proven to be efficacious for them because they're using CMS as their coverage. There are currently legislative pushes to help improve this treatment coverage, but right now it's going state by state. So for example, in Pennsylvania, when I did my fellowship, they do have CMS coverage for anti-obesity medications, but in New York currently we do not. So I do advocate for this, and I encourage you, if you're interested in advocating for this, there's a group called the Obesity Action Coalition that actually goes to Capitol Hill to legislate, but also has letter writing campaigns and things like that that can help us. So what can we do now to bridge that gap? If patients have access to dietitians and surgeries, we have people in the middle who don't have access to those things. One is, again, understanding we're all treating obesity, bridging the gap. We need to understand patients who have obesity are often victims of bias in their homes, potentially their work settings, and in the medical community. So we have to be sensitive to obesity as a condition. Improving access to care, having community-based programs that are easily accessible, whether they're online or the patient is going to a physical place. I know the VA centers have a MOVE program that gives group therapy for weight management that has been effective. Having healthy options like our fruit stands, but also in cafes, vending machines, coverage for dietitians, using obesity codes to diagnose obesity, and really associating the obesity code with the treatment. Having more weight management specialists. There are about 6,000 obesity board certified specialists in the country right now. If you want to become one, I can talk to you about that offline. Having rewards for activity, not only gym memberships, because gym memberships cost money, but walking is an activity that should be rewarded, for example. And medication coverage. I can't stress enough how much easier life would be for patients than for me as a weight management specialist. We have coverage for medications as well as bariatric surgery. and using tools in the EMR, such as BMI, to not only say the patient's weight is high, but then there should be a separate section to say, what will you do about this? Will you refer to a dietitian or weight management specialist? Will you treat this with pharmacotherapy or surgery right now? Will you give some guidelines to the patient, and having easy tools for any provider to give those tools to the patient? So at my center, we actually do have a button that says the BMI is high, what will you do? And I'll be honest, many people ignore it, but it does give the option to refer to weight management, refer to a dietitian, or to give them even a handout about treatment options for obesity. So again, the obesity prevalence in Americans is increasing, and also in adolescents. And the reason we don't see it as much above 60 is because there is early mortality, unfortunately. There are almost 300 million American adults with obesity. 110 million American adults with obesity. And I just bring this up. This number is really astounding. But again, it encompasses that we're all treating patients with obesity. There are now, I should update this because the boards recently got released, the board results recently got released. There are 6,000 obesity medicine specialists. However, if only the obesity medicine specialists treat the patients with obesity, each of us would need to see 20,000 patients, and it's not possible. So I ask for your help in diagnosing obesity, treating obesity with lifestyle recommendations, pharmacotherapy, and if you don't feel comfortable doing that, then referring. I'll talk a bit about provider experience. I'll go a little quickly here. So if a patient who walks in, the patient has these vital signs, blood pressure is high, and a very common response is, well, I'll give you a blood pressure medication, come back to the clinic in 2 months. But if we ignore this BMI of 40, we're really not doing the best we can for patients. So treating the blood pressure is essential to decrease patients' cardiac risk of stroke, et cetera. But we have to address the underlying issue, which is also the obesity. Now, if you see this patient in a sagittal MRI, this is what you would see. So we see a high blood pressure, we see a red alert on the EMR for the BMI. But if you look at this patient, we see the fat within the organs. We see the fat around the heart and the liver. The patient's knees are buckling with osteoarthritis. There can be signs of diabetes, risk factors for stroke. So this is really what the patient with that high BMI looks like on the inside. So we don't need to ignore this when we see abnormal labs or vital signs as well. And I have done some surveys, and there have been many national and global surveys about why certain providers are not treating obesity. And I understand there's not time to do it, I'm not getting reimbursed for it. I really don't know what to tell the patient to do. And also, physicians also can say, I don't feel comfortable discussing weight because of my own weight. And then there's also bias in the medical community. They perceive the patient with obesity as lacking in willpower and essentially futile to treat. The other thing that limits therapy is prior authorization. This is a big hoop that we're forced to jump through to get our patients access to care, whether it's dietitians, medications, surgery. And this is something I have to deal with every day. I did not intend to go to medical school to check boxes about prior authorization. That's a lot of times what we do, or we all put this to our staff. But the problem is with prior authorization, it really takes a lot of the autonomy away from the physician, and because it says you should do step therapy. I know you want to give the patient this highly efficacious treatment, but why don't you try these other treatments and see if they work because they're less expensive? And this is really something that's detrimental to the patient's care and often can limit their access, because if the prior authorization is not fulfilled, the patient will not have access to that medication or surgery, and thus we have that statistic where 80% of the prescriptions that are written are not filled. As far as patients' experience, patients have been surveyed, they feel embarrassed, they don't want to be weighed, they've been victims of bias, and they feel that really treating obesity in a medical setting can be just really futile. I'll just put this out there as a survey of what patients prefer to use as far as term. Women with obesity, and I took this slide from an old study, I will say. So that is why it uses the pejorative term obese women. I took the slide. That is not how we should refer to patients. We should say women with obesity or women affected by obesity. But that's what this specific graphic had there. And these women with obesity prefer to use the term weight rather than other terms such as heaviness, obesity, excess fat. So when talking to patients, I ask them, how do you feel about your weight? I don't say, how do you feel about your large size or your obesity? Because that tends to stigmatize patients. Similar outcomes came with men. I'll just say that in the same study. So how can we optimally treat these patients? We want to have a non-stigmatizing environment and encouraging supportive staff as well as physicians, a multidisciplinary approach involving different types of practitioners. And we want to offer all of the different options for patients. And I understand if you're not an obesity medicine specialist, you don't have to give them all of these, but referral is important as well for patients who are higher risk of morbidity and mortality. And having respect for the patient. So having a good rapport with them, having the right equipment size, privacy when weighing patients, giving them compassion, and using tactful terms such as we mentioned, weight rather than high BMI or obesity. The rapport, taking the time to get to know the patient, speaking to them with compassionate measures, using the right size cuffs, gowns, having tables in the exam room that can help the patient feel comfortable, scales and accommodate wheelchairs, for example. This is a type of chair we have in our office. You see they don't have armrests that makes patient feels more comfortable. We have chairs of different sizes that can accommodate larger patients. We have different types of scales. What you see here is a stand that can help patients get on the exam table if they need help. Different cuff sizes to accommodate different size bodies. Again, different chairs. Safety and privacy. You never want to yell a patient's weight, of course, down the hall or have them weigh in a public area. And encouraging the patients to feel free discussing their weight and encouraging them to come back to talk about that, or again, referral. Making the patient feel understood, heard, and avoid blaming the patient for their weight. And again, tact. These are actually some of my people at my front desk and one of my medical assistants. You want to make the patient feel welcome. So just in summary, I'll leave some time for questions. Obesity is a chronic, remitting, relapsing condition that is affected by neurobehavioral components. BMI, while it's easy to determine, is not the most reliable in diagnosing obesity, so we should use other modalities. Obesity is associated with many other medical conditions, and even though we have these population-based initiatives, they have not really been effective. So we should consider this a medical condition that we should treat with the options of lifestyle modification, pharmacotherapy, and surgery. However, on a policy level, our options are underutilized due to lack of coverage, prior authorization, barriers to access, and obesity does contribute to higher medical costs. All right, so with that, I'll take some questions from the audience, and we only have a couple of minutes. Thank you.